went, she received her Bachelor of Arts from the New College at Hofstra University, and then completed medical school at the University of Pittsburgh and received an MPH at Columbia University School of Public Health in New York. She did her internship and residency at Children's Memorial, and then did a primary care pediatrics residency at Montefiore and Hospital and Medical Center in the Bronx. She's done faculty development training, and she has had leadership positions at a variety of institutions, including the George Washington University. I'm not sure if I don't think we overlapped, but I was there from 92 to 2019. And she's been the she was the director of ambulatory pediatrics at the Weill Cornell Medical Center in New York Hospital, chief of general and primary care pediatrics. She's done extensive work with vaccine, trying to improve vaccine rates and with vaccine hesitancy. And she's a clinical associate professor of pediatrics at New York University School of Medicine and adjunct associate professor at of clinical public health at Weill Cornell Medical College in New York. So looking forward to your talk, Dr. PALEVSKY.
Thank you so very much for your kind introduction, Dr. Ottolini. It's really a pleasure to be here. And at GW, I think I was in the process of leaving just as you were starting. So we may have overlapped by a couple of weeks. What I'd like to do this morning is to talk to you about HPV vaccine and how to think about HPV vaccine, especially in terms of vaccine hesitancy and the myths that we have. As we're, oh dear, I have a pop-up about the being recorded and I can't figure out how to get rid of it. Give me just a second to see. Okay, sorry about that. There's always something technical. I've been asked to remind you that to get credit for this session, please text this number, which I'm sure you're familiar with, so that you can get credit. And I'll show this again at the end. I have no conflicts. I have nothing to declare. I'm here at the, through the Visiting Immunization Expert Initiative of the Academy of Pediatrics, which is funded through or supported by the CDC. What I'm about to say is not necessarily improved by the CDC. What I'd like to remind you about is that although I say I love vaccines, it's not vaccines that are important. It's getting those vaccines into the arm. It's vaccinations that we really care about. But I do love this. I've seen it as a bumper sticker. I've seen it as all sorts of other, I don't know, mugs and things like that. So I want to go over the epidemiology of HPV to define the indications for it, and to talk about ways to communicate to promote and improve HPV vaccination rates. As we look at vaccines in the last couple of years, what we can see is that childhood vaccines really have declined dramatically over the last, or at the beginning of the pandemic. So if we go to the left of this chart, and this is from the New York Times, we were humming along at our usual, and about a year ago, rates really plummeted, and we've made some recovery, but we are not all the way there. And this graph looks particularly at adolescent vaccines, HPV, meningococcal, and MMR but the HPV you can see is down about 35 to 40% as of sort of late June, July. Okay. Okay, there we go. There's still a substantial deficit this year. And this is a chart from the CDC. The numbers 1 and 2 on the far left. 1 is when the first cases of COVID were reported. And number 2 is when the national emergency was declared in the middle of March last year. And this goes through the end of February. And what this speaks to is the decline in orders for the Vaccines for Children program. For other than the blue is measles containing vaccine, and the green line is all other vaccines that are non-influenza. There are some data to suggest that in the private sector, there's been an even slower recovery than in the public sector. Now, turning to HPV, why do we care? Well, at least 43,000 people are diagnosed with a cancer related to HPV every year. And if we translate that into a more minute-by-minute diagnosis, it's about 1 case every 20 minutes. And that's pretty scary to me. Most persons will be infected with at least 1 or more type of mucosal HPV at some point in their lifetime. And HPV is most common in persons in their early teens and 20s. Most people will never know that they were infected. And we need to remember that HPV is a cause of many cancers. So if we look at what those cancers are, we can see that this is for the time period 1993 to 2005. The 3 bars towards the left that are in a sort of paler color are oropharyngeal cancers. But you can see that HPV cancer certainly accounts for an enormous proportion of genitourinary cancers and for oropharyngeal cancers. If we look specifically to the anogenital cancers, and again, this is the period 1993 to 2005, so this is the pre-vaccine era. The blue bars are those cancers associated or caused by HPV types 16 and 18. The light green are other types that are included in vaccine, HPV 31, 33, 45, 52, 58. The reddish bars are HPV negative. So that you can see that only on the far right really are penile cancers. Do they have a substantial amount of HPV negative disease, and maybe some vulvar and vaginal cancers in the middle as well. But clearly, the vast proportion of anogenital cancers, cervical, vulvar, vaginal, anal, penile, are due to HPV 16 and 18. So the take-home message is these are vaccine preventable, and I'll say that over and over. We also need to think about head and neck cancers, which I showed you briefly a couple of slides ago. And these are HPV 16 and 18 here again in blue, and HPV negative in the red. So you can see that total oropharyngeal, tonsillar, base of the tongue are largely HPV 16 and 18, and oral cavity and laryngeal cancers tend to be or more likely to be HPV negative. If we look at, this is in the once vaccine was initiated, so 2011 to 15, and we're looking at females and males, we can see, not surprisingly, that cervical cancer seen in females accounts for almost half of all HPV-associated cancer, with others playing a role. And in males, the vast majority are oropharyngeal cancers. And this is something that we need to remember. So what we're talking about here is cancer due to HPV. If we look at racial and ethnic disparities in cervical cancer alone, again, this is for the period 2011 to 15, the blue bars are the incidence, the golden, orange, whatever, are the mortality. You can see that the incidence of cervical cancer is there across the board, but there are racial disparities both in incidence and mortality, with persons of color bearing a disproportionate burden of this, and our indigenous American Indian, Alaskan Native groups as well. If we look at HPV vaccination coverage among adolescents in the United States, there are other differences that we can see. Social determinants of health play a role here. We have those below poverty level are more likely to have their vaccines up to date, and those who live in more urban settings are more likely to be up to date. Now, these are data from 2017, so it's a little bit older, but we have no reason to believe that this has changed at all. And as we might expect, girls are more likely to be up to date than boys. And up to date for HPV means having completed the series. Again, going back to the HPV types that we find in common cancers, to show you what's covered by the different strains in vaccine. And now we are looking at the 9-valent vaccine. On the far left, cervical cancer covers just about, I don't know, 85 to 88% of all cervical cancers, about 80% of all anal cancers, and about almost 70% of all of the oropharyngeal cancers. So again, this is really an anti-cancer vaccine. So we don't do a great job promoting this vaccine. If we look at the incidence of diseases that are preventable by the typical vaccines that we give, everyone gets very excited about meningococcal disease. Now, admittedly, it's a horrible disease. It's very dramatic, or can be, in its presentation, and it can have horrifying outcomes immediately. But the annual incidence of meningococcal disease is really very low. On the other hand, pertussis, and we are aware of, for adolescents, Tdap vaccine has an annual incidence of about 5.5 per 100,000. But cervical cancer and oropharyngeal cancer, HPV related, are up there, with cervical cancer being even higher. But we do a less good job, that's bad grammar, in getting vaccine into our adolescents. If we look at sort of how this vaccine works, if we get, and this is an older slide, but it gets the message across. If we aim to get persons vaccinated, our adolescents vaccinated, starting at age 11, and we want to have it on time, so I'd rather see this as 11 to 12 and not extending up through, say, age 20. We get the vaccine in, and what we see is that having the vaccine would interrupt acquiring genital HPV infection and developing precancers and cancers down the road. So let's look at this a little more closely. This is a study that was published in 2017 that compares the pre-vaccine era, 2003 to 2006 in purple, the early vaccine era in green, and the later vaccine era in blue. The later vaccine era is when we really had expanded recommendations. And you can see that among girls who were vaccinated, we started seeing a remarkable decline in HPV infections. And since we get vaccine, we're focusing on getting it into 11 and 12-year-olds. We're seeing that decline by the time the child is about 18 or 19. The older kids, we might not see as big a decline because they've already been exposed. So this is really impressive. HPV, this is a more recent estimate of infections that have declined since the introduction of vaccine. And remember that the quadrivalent vaccine was introduced in 2006. So we've seen among teenagers an 88% decline in HPV infections and an 81% among young women. And young women is defined as 20 to 24 here. So let's look at the vaccines themselves, or the vaccine. It's a recombinant vaccine. It forms virus-like particles. The picture here is a cartoon to show you what it might look like, or what it does look like. This is very similar, if you will, in how the hepatitis B vaccine is a virus-like particle. It is non-infectious and non-oncogenic. So if I were to take the material in a vial of vaccine and try to grow it on viral culture media, nothing would grow. And as we see in many cases with vaccine, the vaccine produces a higher level of neutralizing antibody than does natural infection. This is a sort of a cartoon of the HPV types that are included in vaccine. Some of you may remember when we had the quadrivalent vaccine introduced in 2006. That was made by Merck. We had a bivalent vaccine that became available in the United States. It was only available for a short period of time. That was made by Glaxo, brand name was Cervarix. And we currently have a 9-valent vaccine that was introduced in 2014. And this shows you how they covered different strains and the proportion of disease included in each of them. So the schedule for vaccine, the guidelines are, we start talking about it, and we can start talking about it pretty early. In my inner city practice, we would talk about it even before age 9, saying that when your child turned 9, then we will go ahead with this. The on time in the schedule is at ages 11 to 12, along with all at the adolescent platform, and then we would be catching up. The advantage to getting this vaccine in early is that if the doses are started before age 15, it is a 2-dose series. If we start at age 15 or older, it is a 3-dose series. The vaccine is licensed for those up to age 45. We tend not to take care of people that old, whereas it is a routine recommended vaccine and ought to be offered to everybody. In the younger age groups, it's considered a shared decision-making for the older group. And quite frankly, I'm not certain that that's an effective way of communicating, but you know, I'm a pediatrician. So the schedule simplified here is if you're initiating vaccine ages 9 to 14, it is a 2-dose series. With the exception if somebody is immunocompromised for any reason, they default to a 3-dose series. If you're starting at age 15 or older, or for anyone who is immunocompromised, it is a 3-dose series. The first dose is given for the 2-dose series. The second dose should be given at time 0, 6 months later. It can be any time thereafter. There is a minimum interval of 5 months between the first and second dose, but that doesn't mean that we should rush to get it in sooner. In the 3-dose schedule, the minimum interval between the first dose and second dose is 1 month. And then the minimum interval between the second and the third dose is 12 weeks, but there must be an interval of 5 months between the first and the third. And we are accustomed to these kinds of intervals. HPV vaccine may be given at the same time as any other vaccine. When we're giving it, generally, I recommend giving this one last in the series because kids complain that it does hurt. It feels like somebody punched you in the arm. As I said, for immunocompromising conditions, including HIV infection, it's a 3-dose series for all ages. If you take care of somebody or you're seeing somebody who has a history of sexual abuse or assault, or you have reason to be concerned, earlier is better. Now, this is the only vaccine that actually has a safe in pregnancy FDA approval, but that doesn't mean that we wish to give it during pregnancy. So if a patient of yours gets a dose and is then discovered to be pregnant, we need not do anything. You don't have to do testing. It's not an indication to tell them to be particularly worried or concerned about the pregnancy. And you just delay subsequent doses until the pregnancy is completed, whether that's by delivery or by termination. This is a graphic that shows adolescent vaccine coverage here in the United States. This was published about a year ago, or August in 2020 in MMWR. And this looks at the doses. I've marked here HPV initiation is kids getting the first dose, and we have made remarkable progress so that we're about 60% or so of kids get a single dose of vaccine, but completion is really much lower. We're down somewhere around under 50%. And there were different recommendations early on until it was recommended for boys and 3-dose versus 2-dose. But you can see, at least since 2018, we're really not doing nearly as well as we do with our other adolescent vaccines. This is published in 2017. This is looking at adolescents, and again, looking by poverty, urban, rural, and gender, to stress that we're not doing as well as we could be. This is more recent data from the National Immunization Survey, looking at initiation by sex, completion or up to date by sex, and then by race and ethnicity. In the gender, females are in the blue, males are in the orange or gold, whatever color it's showing up for you. And race, ethnicity, the Hispanics are blue, non-Hispanic black is the sort of orange. Non-Hispanic whites are the gray. And that's a little surprising to me, but nothing ever surprises me. And then there's an other category. Again, the point here is that there are racial disparities. So what are the reasons that are given for not starting the vaccine series? This was a survey that looked at asking parents why they didn't vaccinate. Blue is boys, the pink is girls or sons and daughters. And there were some concerns about side effects and safety, that it wasn't needed. That bothers me. And then we have the not recommended. And that's something that we as pediatricians, we as adolescent health clinicians can really do something about. We can remind people that HPV vaccine prevents about 92% of all HPV attributable cancers that we would see down the road. For some families, for some clinicians, guilt works really well. Saying to a parent, particularly to a mother, asking, do you know somebody who has had an abnormal pap smear? We can likely prevent that for your daughter. If we look at HPV initiation and completion rates in the younger group here in the US, this is in 2018, and I want to focus on Maine since that's where you are. You can see in 2018, initiation was not so bad. It was sort of at the average, you know, a little bit above 50%, but completion rates were not nearly as good. Certainly somewhere around 30 to 40%, as we're judging from the color on this map. We know that families that received a recommendation from their clinician were much more likely to get vaccinated. And a strong recommendation is much better than a weak recommendation. If it's presented as, well, you know, HPV, we have HPV vaccine in the office, do you want it? I don't know very many people who rush to get vaccines, maybe with the exception of some of us who really were eager to get our COVID vaccines, but most people don't want vaccines. If it's a wishy-washy or low quality recommendation, you're not putting your heart into it, maybe it goes up to half of individuals will accept vaccine. But if we make it a high quality recommendation, and the language we use is same way, same day, then we are much more likely to see acceptance. Since we offer this most of the time along with the other adolescent vaccines, if we're doing it age 11, the way that would be is today your child is due for vaccines. That's your Tdap vaccine, the HPV vaccine, and the meningococcal vaccine. I'm going to go ahead and get those ready if that's okay. That's the same way, same day recommendation. But we know we see a lot of vaccine hesitancy. That's not a new phenomenon. This is a cartoon from 1802 that satirized Jenner, who's wearing that suit coat standing over the woman who's seated, and he's giving her cowpox. And you can see the people on the right who've already been vaccinated developing bovine features. So parents want to do what's best for their child, but there's an awful lot that's going on, and it's hard to figure out what to believe. So we've got a parent there. We, as the clinicians, I hate the word provider, but that's what's in this slide, are telling them one thing, are making suggestions. Our general community might be saying, or your community, the place where these folks live, may be saying something else. There's influence from public health and the large anti-vaccine group that's feeding into the media and internet and into the press now. And all of this is landing on the parent, and they're trying to figure out who to believe and what to make of all of this. If we look at it on a continuum, in the green, we have the acceptors, the pro-vaccine folk. They have relatively few concerns. Their kids are fully immunized. They trust their clinicians. They're interested in information. And that's about 70% of families. In the middle, we have the vaccine hesitant. They're unsure. They might delay. They might pick and choose among vaccines. Typically, their children are under-immunized. These are the ones who want to wait with the MMR until they're 10 years old or something like that. They want to talk to somebody who's trustworthy. We have to figure out how to become that most trustworthy of all person and not some internet clinician. And they are generally interested in vaccine information from you, the child's primary care or even specialty provider. The anti-vaccine people, the rejectors, the ones who don't want anything, those kids are unimmunized. They have relatively low trust in their health professionals. They're not interested in information. Typically, this has been under 1% of the population. And a lot of this is influenced by complacency, convenience. It's going to assume that vaccine services are available. And it's going to vary with context and vary across time and place and specific vaccines. So we use what we call motivational intervention tools or motivational interviewing. And this is asking open-ended questions. So tell me, what are your concerns? And then waiting for them to talk. Silence is okay. We don't have to rush in. We need to give them time to feel safe to ask their questions. We want to reflectively listen. That is, when families tell us something, we want to say, what I hear you saying is, or I think I understand you to say that. We want to talk about the options, the pros and cons of making a change, and ask how comfortable they are and how important it is to them. We want to summarize what the family is saying to us. Again, a strong clinician recommendation is the single best predictor of vaccination. Now, I say here that parents and physicians may speak different languages, and I don't mean that I speak English and my patient speaks Portuguese. I mean that I speak medicine and science, and my parents, the families, are speaking vernacular and emotion. And we have to get those to connect, because in the absence of that, there's really no overlap. Our goal is to persuade, not to win a debate. We don't need to correct every erroneous idea, but we have to remember that somebody who has a really deep belief system, that belief is going to win out over science. That belief is stronger than proof. And a belief won't and can't be changed by evidence. I often use as an example, I will here, that there are people who still belong to the Flat Earth Society. And these folks believe that all of the pictures taken from our astronauts circling up in spaceships, of the pictures taken of the globe of Earth are constructs, that it's not really like that. They believe that the Earth is a platter and you're going to come to the edge and you're going to fall off. I have a hard time believing that. I mean, I've traveled not around the world, but far enough to be able to know that when I've been to the Philippines, when I get to the Philippines, the globe doesn't end. When I've gone the other direction, it hasn't ended. I haven't fallen off, but people do believe it. We have to acknowledge that social networks help to form or reinforce beliefs, and social networks are reinforced or strengthened by social media. So everything on all of the various internet sites, all of the social media sites, those are communities that speak their own languages and have their own belief systems, and it's hard to penetrate. If we as physicians attack their beliefs, we're going to lose the ability to persuade. So we have to approach it a little differently. Again, we need to ask, we need to listen, we need to use body language. It astounds me the number of people who, when a clinician is with their patient, they're standing up, towering over their patient. We need to be all seated, all at the same eye level, being comfortable. We need to use good body language, physically leaning in, not stiff and, scary looking. We need to keep checking back with the family when we're asking and talking and listening. As I said before, we need to summarize what we've heard, and we need to affirm that the parent is comfortable. So if I'm trying to talk about HPV vaccine, and I've gone through and talked about it as an anti-cancer vaccine, and I know the parent is concerned because of what they've heard on the internet and what their neighbor says, and they tell me about their friend's cousin's next door neighbor's buddy. We've all gone that route. We need to be able to say, I know that you're scared by all of this, or I think I'm hearing that you're scared by all of this. Can we talk about the things that are the most important to you? And sometimes it's really making a specific recommendation. We don't want to profile the parent or family. Oh, you're one of those who doesn't believe in. I've talked about bundling recommendations. We want to make certain we ask for all of their questions, and that may include the teenager's question. We want to answer questions accurately and calmly. And the second question, some people say, or I've heard that, it's exasperating, but don't give out a big sigh. Stay positive. Sometimes it's showing real caring. I would feel better if I knew that your child was protected. I've seen too many kids who have had. Now, I'm old enough to be able to say, for example, I've seen too many kids who have died of chickenpox. I don't want that to happen to your child. Or when a Hib vaccine came out, I mean, I spent a good portion of my early years as a pediatrician taking care of kids with epiglottitis and or H. flu meningitis. And I was able to say, I don't want your kid to have this. This is scary. Now, people were scared of those illnesses. They heard about them because they were common. We don't hear as much about cervical cancer. We know that women go for pap smears. We know that there's, if there's an abnormal pap, you have to go back and be followed up. You know, we can say, I don't want your child to go through this. We can use examples. Find some celebrity who supports it if that's what you think will work in your practice. Many parents will just accept your recommendation if you make it, but we have to make it. Some parents are going to have questions. So turn around and interpret that question as they need reassurance from you, the clinician they trust, and make certain you're addressing their real concern. I will say that for boys, I've sometimes found it helpful to show pictures of penile warts. And once a boy sees a picture of warts, they're on board. And usually fathers are pretty eager for that as well, for vaccine when they see those pictures. You need to make certain that your entire office is on message. If one person is going to undermine, if one person says, well, you know, I didn't get that vaccine, or I don't think it's important, it's not going to be a successful practice. So everybody has to be on board. There has been, as you are aware, aggressive media attention to concerns of the vaccine anxious, and lots of discussion about vaccine hesitancy and the anti-vaxxer populations. But we also have to acknowledge that the social determinants of health play a large role in kids not being up to date with vaccines. And this is something that we need to focus on. I've mentioned a little bit about language, translation service, but more importantly, it's health literacy and comprehension. And if we give families things to read that are not in the language that they read, they may not read, they may be illiterate, they may not understand it. And health literacy is often not as comprehensible as we want. There may be issues of transportation, depending upon where you are. If somebody has an appointment to come in and they can't get access, there's no car, there's no public transit system, how are we going to deal with this? There are certainly differences, as I've shown you, in urban, suburban, and rural health uptake of vaccines. How far are we from primary care or community-based care? What about insurance status? Private insurance, public insurance, no insurance. If somebody is completely uninsured, do they have to go to a federally qualified health center to get vaccine? So does that mean another day off from work and finding transportation to get there? What about immigration status, documented, undocumented? I hope that fear of the public charge has diminished. I'm not going to talk about that today. That's a completely different subject, but immigration status is certainly a marker for differences in vaccination status. And what about the family structure and family dynamics? Is it a single parent family where to get the kid vaccinated, that parent has to take off from work and isn't going to get paid? If there are multiple kids, in order to take one child to be vaccinated, does mom need to, or dad, or whoever need to take all the other kids out of school as well? And in many places, it's easy to find excuses for vaccines for school requirements. HPV is not typically a school requirement anywhere, but there are easy excuses to avoid getting vaccines. A colleague of ours, Todd Wolin, who's in Pittsburgh, says, how do you make the HPV recommendation? And why do you say it that way? What can we do to make it better? There's a tip sheet from the CDC, and all of these slides will be available to you. There is a good training, interactive role-playing tool available called Same Way, Same Day that can be downloaded. There's lots of information that I've provided here for you in these resources, a number of videos that I would encourage you to see. Someone you love, the HPV epidemic. This, I've included here a snippet, an excerpt from it. It's available on YouTube. The entire thing can be viewed. It's older, but it is really powerful. I encourage you to watch it. And then some videos on making recommendations and the office team. And I would remind you, I'm sure you all do, but to report all vaccines to your immunization registry. And that would include historical vaccines given elsewhere that are not in your immunization information system. Make certain you enter those as well, please. I thank you for your attention, and I will be happy to try to answer any questions that you might have. And again, for credit, please text this number as you know what to do. Thank you so very much.
Thank you, Dr. PALEVSKY, on such an outstanding talk. I can bring up the chat and the Q&A if that would be helpful.
Sure.
Dr. Ashley Speckert, who is one of our pediatric oncologists, asks, are there any studies evaluating the protective effect of the HPV vaccine in individuals who've already been exposed to HPV? Could HPV vaccine boost the immune system and prevent HPV cancers?
The answer is yes. Now, remember that right now we are talking about a 9-valent vaccine. And when somebody is exposed, we don't necessarily know which one of those strains somebody has been exposed to, or it may be a non-vaccine strain they've been exposed to. So the reason that vaccine was licensed initially for the younger kids and then expanded to the young adults and then to adults up to 45 is that it's much harder to find individuals who were naive to be able to show efficacy. Because if we look at women who are 25 and have been sexually active, they are more likely to have already been exposed. But that doesn't mean that they're necessarily exposed to all of the strains in the vaccine. So there will be some, protection. I will say, and this is something I was completely unaware of, a dermatologist told me that there are early studies to look at using, and I thought this was really fascinating. I'm sorry, I learned this yesterday evening, looking at using HPV vaccine to in persons who have squamous cell cancer, skin cancer, and to help with resolution of that. It somehow primes the system. I think there's one study that's been published, but the dermatologists are really keen, and it doesn't even include, we don't think of the 9 strains that we know of being associated with skin cancers. So I'm fascinated by this to see where it may go. We do not have any data, and I want to make this clear. There are no data to suggest that persons who get HPV vaccine are not going to get skin cancer. So please don't take that message. Use sunblock.
All right, another question from Dr. Kobe Wyatt, who's one of our pulmonologists, is if it is FDA safe, why not give the vaccine to pregnant women? Isn't there a potential protective effect for the fetus and infant during birth that could prevent mother-to-child transmission of the virus and potentially future oropharyngeal cancers and laryngeal papillomatosis?
I absolutely agree. I think the issue is that we are extraordinarily reluctant to test vaccine in women who are known to be pregnant. What happened for HPV to get safe in pregnancy guidance is that enough women in the initial trials who, when they signed up, promised, signed off that they would use 2 methods of birth control. Enough of those women got pregnant and carried those pregnancies to term that they could be followed to see with a registry that there was no adverse effect either on the pregnancy or on the newborn. But for the FDA to license something as recommended in pregnancy, I think there needs to be enough data to show that it has some benefit to the newborn. We've done that for flu vaccine. We know that women who get flu vaccine, and flu vaccine is recommended for all women who are pregnant, as is Tdap, because we know it protects the newborn. I just think there aren't enough cases of babes being born with papillomatosis, and nobody would be able to do a great controlled study. But if somebody were to try to look at the data, it might support it. So if you can get a consortium of people who are interested in studying it, looking at babies born and diagnosed with papillomatosis early on, and see whether their moms were vaccinated or not, it might be the beginning. I think that's a great study. I'll be happy to help with it if somebody's interested. I'm not in clinical practice anymore. I have no access to patients.
Just in follow-up to that, do you know if the rate of laryngeal papillomatosis in infants has declined with the increase in HPV vaccine rates?
I've heard that anecdotally. I've not seen any studies about it. I think any of us could do a literature search to see if something is there. Mm-hmm. If there's somebody from ENT who's participating, please speak up and add in what you might have be seeing. I don't know. Yeah, so I invite Dr. Wyatt to weigh in on this since we don't have an ENT doctor on the grand rounds today, but Dr. Wyatt certainly deals with this issue, or one of the other pulmonologists who's on. I don't know if they can be unmuted, but if you want to put something into the chat or the Q&A, that would be great. Oh, there's Kobe. Do you want to unmute yourself, Kobe? Well, while we're trying to.
Sorry, my audio is cutting out.
Great. Go ahead, Dr. Wyatt.
I'm sorry, my audio cut out. I missed the first part.
Oh, just wondering if you've seen a decline in the number of laryngeal papillomatosis cases with the rise in HPV vaccine?
Um, it's a great question, and I have seen less of it, but I had a transition in my professional career that would lead me to see less of it. So I don't know the answer if there's been fewer cases diagnosed. I'm not sure the answer. No, it first came out where I was working before. There was a lot of hope that it was. I just haven't seen that many cases since I've been here, and I'm not sure of the numbers, and I haven't followed.
All right, thank you. One other question that I have that I've heard from primary care providers at Maine Health is we measure HPV vaccine rates as the number of 13-year-olds who are fully immunized by their 13th birthday. And the question came up like, well, why can't we just push it back to 14? Because parents or pediatricians or the combination are reluctant to talk about a vaccine that prevents a sexually transmitted virus at age 9 or 10. So can you comment as to how you present that? I know you mentioned it for 9 to 10-year-olds, and I'm sure this must be an issue that you hear frequently.
Yes, it is. So I try to take the sexually transmitted out. So the question is, why do you use 14 as the measure? And I'm out of the institutional practice for long enough. I think that's the HEDIS measure.
Yes.
And you're not going to change national guidelines.
Right.
So why do the assessment then? Because that's what it is. I think if you start talking about HPV early on, at early ages, as cancer, as throat cancer, yes, it's cancer of the anogenital tract, that gets people riled. But the idea that we really want to get across is this isn't about sex, it's about protection. And we know that the younger you are when you're vaccinated, in fact, the more robust the vaccine protection is. And I think I have a slide that was hidden, I'll see if I can find it, that looks at the seropositivity. Now, I'm not going to talk to parents about seropositivity. That's science language. But what we can say is that we know that, let's see if I can get this to show. No, I can't. That we know that if you get vaccine at an earlier age, it works better. And there are good data on that. And there are some people, some of our colleagues, where parents are reluctant to get 3 vaccines at a time. So if you start the HPV at, say, 10, and your school requirement is for, and I don't know what it is in Maine, your school requirement for Tdap is at age 11, then you can get, there are fewer shots. And by the time you get to age 11 plus, you're done with your series. Even if you get one at age 10 and the second dose at age 11, that's okay. But I think we need to work to reframe about sex and talk about it strictly in terms of cancer, because cancer is scarier. Now, that said, it still is cervical, penile, and those are you know, that's sex to a lot of parents, but I think you just have to keep plugging at it. And, you know, a line that I've heard has been helpful, or an approach that's been helpful for some families, has been that I know you want to be grandparents someday. And, you know, as kids get into the teenage years, it gets to be, life gets more complicated. Let's get this on board now so we don't have to even think about it later on.
Yeah, those are great suggestions.
Another colleague likened it to teaching kids to cross at corners. You let them go by themselves, you know, first, with you trailing behind. You have to get them ready to learn to know how to cross the street before you let them do it alone. So what you're doing is you're preparing them for the eventuality of their being sexually active. Then there are some people who have tried, you know, and I think it's a little scare tactic, but it may work. You know, I know that you've raised your child, your daughter, to be sensible and not be interested and not going to have sex before she's married, or whatever lines you use in whatever community you have. But you can never know what might happen. And this way, should something happen to her that we're not planning for, she's going to be protected.
Yeah, those are great ideas. Thank you. And I think it's been a great use of an hour, great information and suggestions as to how we can improve our HPV rates. And we certainly will make the recording of your presentation available to those who weren't able to attend today. So thanks again. Hope the weather is good in New York.
Oh, it's glorious. And if there are any questions that folks have, please feel free to forward those emails or give them my email directly. That's what I'm here for.
Okay, thank you again.
Take care now.
Bye.